Hello everyone, welcome to the channel. This will be a pathology video on clinical features and laboratory investigations in ischemic heart disease by Dr. C.S.B.R. Prasad, Professor of Pathology, Sri Devarajaras Medical College.
So what are the clinical features of AMI? Prolonged chest pain, more than 30 minutes, and it is centrally located, retrosternal, and radiating to the left arm along the ulnar border into the tip of the left, left little finger. And this may be associated with nausea, vomiting, or the patient may have sweating, profuse sweating, or he may pass motion and stool. And there are certain conditions where acute MI may not be associated with development of typical chest pain, which is described earlier. So what are these conditions? Diabetic neuropathy. So the chest pain may not be very obvious in a patient who is having uncontrolled diabetes for a longer time, who developed neuropathy, or the persons who underwent cardiac transplants may not exhibit typical acute myocardial infarction associated chest pain. And the patient will have dyspnea, especially when the left ventricle is involved, and the patient dyspnea due to pulmonary edema. And diagnosis of MI, typical symptoms which is described already and associated with biochemical changes and ECG pattern will help you to clinch the diagnosis of acute myocardial infarction. And remember, 10 to 15% may have silent myocardial infarction, which is just an incidental finding when the patient walks into the casualty complaining of tiredness. Okay. So these are the ECG changes. You can see the ST segment elevation, T wave inversion, and in the world infarcts, probably the patient will have deep Q waves. And diagnosing MI, diagnosing by laboratory methods, we have some enzymes or the proteins which can be estimated in the serum, which will help us to diagnose MI. So what are those proteins? Cardiac specific troponins, so known as troponin T, troponin I, and enzymes like creatinine kinase, CKMB especially, and LDH, lactic dehydrogenase, AST, and the protein again myoglobin. So this time of elevation of CKMB and troponins are almost same. That means they start elevating within 4 hours and they reach peak and then stop dropping. But what you should remember is CKMB and troponin, they are equal to start raising with respect to time. So they are almost equal to each other in their elevation with the time of occurrence. And CKMB, troponin I, peaks within 24 hours and then the CKMB returns to normal within 48 to 72 hours, whereas troponin will take 5 to 10 days in the case of troponin I, and in the case of troponin T, it may take even 2 weeks for the return to the normalcy. So what you should remember is, in the early MI, if you want to diagnose, you can either ask for CKMB, troponin T, both are equally good. Within 4 hours they start raising. And if you want to recurrence of the myocardial infarction, CKMB, after 3 or 4 days, CKMB is helpful, and this is the earliest one to disappear within 2 days to 3 days, whereas troponin will take longer periods for disappearance. And you can see that diagrammatic representation of myoglobin, CKMB, and troponin I. So troponin I and CKMB simultaneously start raising, but notice the red one which is represented by myoglobin, that is the earliest marker. Within half an hour it starts raising, but unfortunately it is not very specific marker of myocardial infarction. And troponins are the proteins that are associated with contractile elements, the myosin and actin, and these will get detached when there is cardiac anaxia, and they diffuse through the cell membrane because cell membrane cannot maintain its integrity because of low ATP levels, and sodium potassium pump fails, reactive oxygen species damages the cell membrane, and cell membranes become leaky. So this troponin protein leaks into the circulation, which can be estimated. So troponins, these are the proteins that regulate cardiac calcium mediated contractility of the myocardial elements, and troponin T and I will not be identified normally in the normal person, and their detectable levels usually indicate there is cardiac damage, and they both are very specific for myocardium, and rise within 4 hours, 2 to 4 hours, and peak within peak in 48 hours, and come down to normalcy 7 to 10 days, or at the end of 2 weeks, depending upon the type of troponin you are looking at. And CKMB is another isoenzyme, and we have different varieties of CKs. One is CKMM, which is seen in skeletal muscle, BB, brain and lung, and MB is primarily confined to myocardium. So if you are suspecting myocardial infarction, it is better to ask CKMB rather than total CK. CKMB rises within 2 to 4 hours. And so this is another important slide you should remember. The absence of any change in CK or CKMB during the first 2 days of chest pain and of troponin in the days following is essentially tells that the patient is not suffering from any myocardial damage. And this is a diagrammatic representation of different enzymes and proteins that will help us to identify myocardial infarction. Notice that AST and AST is the one which takes longer duration, that is 12 hours, and it will take 7 days to come down to normal. LDH also 7 to 10 days is the duration after which it will come down to normal, but LDH starts raising only after 24 hours. So in acute myocardial infarction, troponin, CK are the ones which are helpful in diagnosing acute MI. So if you have recurrent MI after 4 days of initial MI, so what is the marker you are going to use? It should be the CKMB. That will help us to identify, because CKMB disappears after 3 days, and if it starts rising again after 4 days, that indicates that the patient is having second myocardial infarction.
Thanks for watching. Do subscribe to this channel.